Hello everybody. Today I'm going to discuss about the management of coronavirus disease 2019. Myself, Dr. Bharath Kathi. I'm a consultant chest physician, interventional pulmonologist, and DAMS faculty. And this video content is made only for informational and educational purposes, and it is not a substitute for any professional medical advice, diagnosis, or treatment. And for any reference, see, the guidelines are changing every day, so you should follow the national guidelines if at all there is any modification in the coming days. So first of all, let us see the important clinical features. See, it is just like any other flu-like illness. So patient can have most commonly fever. See, the most common feature seen in about 88% was fever. So there can be dry cough, shortness of breath, and fatigability, and it can progress into respiratory distress. And important features here are the incubation period. So to precisely tell, it is not exactly known. Report says it is about 2 to 14 days. And pneumonia is considered as most common and severe manifestation of the infection. So it is just like it is going to lick your throat and finally bite your lungs. So pneumonia is a big problem associated with this disease. And in United Kingdom, they have also reported a specific symptom called as anosmia. So majority of the patients there who were COVID positive were having some problem in their smell also. And the presentation, in about 80%, it is only mild to moderate disease. So in majority, it is mild to moderate disease, self-resolving. And 13% may progress to have a severe disease. And critical illness, which will manifest as respiratory failure, septic shock, multi-organ dysfunction or failure. It's a complication of any infection in your body. So it can result in some sepsis, multi-organ failure, because lung is predominantly involved. It can also result in respiratory failure. So it is only less than 60% of the cases. So one good thing with COVID is, so majority of the patients who are infected will usually present with a mild to moderate disease, generally mild disease, and most common manifestation is fever here. Then whom to suspect? So when do you suspect that this patient might be having COVID? So first important thing, history of international travel during the last 14 days or close contact with a confirmed case of COVID-19 in the 14 days prior to symptom onset. So one should be international travel, and next is close contact. And also frequently these infections are arising in healthcare workers in the hospitals. So symptomatic healthcare worker managing some respiratory distress or severe acute respiratory illness. So in these people, we can suspect these might be having COVID-19. Then coming to the diagnosis. So diagnosis, the important samples, we take a swab from the nose or the throat. So nasal swab or throat swab. If patient is having cough, we can also test it in sputum. So in critically ill patient, we can take the aspirate from the endotracheal tube, or we can do bronchoscopy. But in majority, so this nasal or throat swab is generally enough, because most of the people usually present with mild to moderate illness. And testing is by real-time polymerase chain reaction, reverse transcriptase polymerase chain reaction, that is PCR. So where we can identify the genetic material of the organism. And if the initial testing is negative, but you are having high suspicion for coronary viral disease, so WHO recommends resampling and testing from multiple respiratory tract sites. So as of now, whenever you are suspecting this patient is having some COVID-19, so the test that we do for confirmation is usually PCR in our country. And what is the current testing strategy? So current testing strategy, so it was given by our ICMR, Indian Council for Medical Research. and this is changing very frequently, but as of now, according to this date, this is the testing strategy. So first important thing, all asymptomatic individuals who have undertaken international travel in the last 14 days. So again, most important people to be tested are those having international travel. And whenever he comes back to our country, so they should be advised home quarantine for 14 days, and they should be tested only if they become symptomatic. So there is a person who has recently returned from other country, so he's not having any symptoms, so just ask him to stay at home. If at all he develops symptoms, so then he should be tested. And all the family members living with confirmed case should also be quarantined. Then all symptomatic contacts of laboratory confirmed cases. Now suppose this fellow was residing in a home who came back, he developed symptoms, later COVID positive. And also now in his home, some of his relations has developed symptoms. So in this condition also, you should test the symptomatic contact. And all symptomatic healthcare workers, because healthcare workers, we don't know with whom we are dealing with. So if you become symptomatic in this time, you can also get tested for COVID. And all hospitalized patients with severe acute respiratory illness. So you don't know about his travel history, his contact history. He presented to you with severe acute respiratory illness. He is in the ICU and you don't know what is causing this disease. So in this condition also, you should get the patient tested for COVID. And asymptomatic, direct and high risk contact of a confirmed case. So previously it was symptomatic contact. Now this you see here, asymptomatic, direct and high risk contacts of a confirmed case should also be tested once between day 5, day 14 coming in his or her contact. So when do you call this is a direct high risk contact who live in the same household, and also healthcare workers with a confirmed case without adequate personal protection measures. See, direct or high risk contact is who are living or traveling with this patient in a very closed space. And healthcare worker, whenever you are dealing with this patient, you don't know about the status and you have involved in care of this patient without the personal protection equipment. So in these conditions also they will be tested. So as of now, symptomatic people who have undergone some international travel, symptomatic contacts of lab confirmed case, all symptomatic healthcare workers and all hospitalized patients with severe acute respiratory illness. So in these conditions, we generally go for COVID testing. And what are the other investigations? So the WBC count, it can be normal or sometimes it can increase. And most important here was they have identified the lymphocyte count to be low. So in about 70 to 80% cases with COVID positivity, lymphopenia was seen. And neutrophils can be normal or high, platelets mildly low. So C-reactive protein, indicator of some inflammation, it is high. So lactates can be mildly high, troponin can be high, urea creatinine mildly high, albumin was low, so the creatine kinase was high. So even the liver parameters slightly high. See, all this indicates some systemic inflammation in the ongoing organs. And ferritin level was also found to be high. And one important thing that we have observed in the majority of the studies was high D-dimer levels. So whenever there were high D-dimer levels and severe lymphopenia, so it was associated with more mortality. So patients presenting with high D-dimer levels and severe lymphopenia, see, all these are some non-specific findings, but studies have found out that patients with high D-dimer levels and low lymphocyte count were associated with more mortality. Then coming to a COVID-19 rapid kit test. So this is detecting the antibodies against the virus. So it detects the IgG and IgM antibodies. The principle is lateral flow immunochromatography. So this was frequently done in Chinese population, and it can be used for screening of carriers. So before they can develop symptoms, so symptomatic or asymptomatic. So you can see these were the commercial kits done in China. So first one, so it is only control is positive, test is negative. Now you can recognize here in this both control and test have become positive, and they detect IgG and IgM antibodies against SARS-CoV-2. So COVID-19 is the name of the disease. So severe acute respiratory syndrome coronavirus 2. So it is the name of the virus resulting in this disease. So recommendation, despite the promise, there is no definitive evidence regarding the utility of rapid kits. So as of now, if they ask you the confirmatory diagnosis in our country, it is not with these rapid kits, it is actually with the PCR. And chest x-ray, just like any other pneumonia, so one can find some bilateral or lobar or multilobar infiltrates. So initially chest x-ray can also be normal. Whereas coming to CT scan, so nothing specific, but most important thing, in majority they have found ground glass opacities. So ground glass opacities is considered as the most common finding associated in CT scan of a patient with COVID-19. And usually it can be bilateral involvement and more deposition in the posterior and peripheral part of the lungs. So bilateral involvement, peripheral and posterior part of the lung, the infiltrations were seen. So this is an example for mild haziness signifying ground glass opacity. So other findings, you can also notice increase in density consolidation. So mild haziness is usually ground glass opacity. So here you can also notice consolidation. So we have seen here. So these are the important findings: ground glass opacities, consolidation. Then what are the clinical syndromes associated with the COVID-19? So mild, moderate or severe illness. So generally mild illness, patient might be having some fever, sore throat, myalgia, and severe pneumonia. So when do you suspect? So whenever there is a fever plus one of the following: respiratory rate is high, there might be respiratory distress and hypoxemia, SpO2 less than 90%. And severe illness includes the presence of some severe pneumonia, ARDS, sepsis, septic shock. So all these are considered as complications: ARDS, sepsis and septic shock. See, the definition remains the same. So for ARDS, we generally follow the Berlin criteria. So onset of symptoms within 7 days, and chest x-ray showing bilateral diffuse infiltrates, presence of non-cardiogenic pulmonary edema. So origin of edema is non-cardiogenic. It cannot be explained by any cardiac disease, pleural effusion or some other collapse or anything like that. And PaO2 by F5O2 ratio less than 300 mmHg. So for ARDS, it is same as the routine Berlin definition. And treatment protocol. So this treatment protocol is something I simplified. So each and every state and each and every country has a different treatment protocol. So this is just for educational purpose. So that you can remember it and represent it easily wherever required. So there is a patient who was found to be COVID-19, and anywhere while dealing with COVID-19, kindly take very good personal protection measures. So you cannot just go like this and handle these patients. So anywhere infection prevention control is very, very important, and personal protection measures are very, very important. So this fellow has presented to you with mild illness, or another patient with COVID-19 moderate to severe illness. So if it is mild illness, what are you going to do? So as of now, the cases are not many in our country. So we try to admit all the COVID positive patients, but in majority of the countries, if it is mild illness because of increased patient load, they are advising home isolation only. Maybe if in our country also cases increase, so mild illness, we might only advise home isolation. But in majority of the states, now we are admitting him because to decrease the risk of community transmission. So we generally give symptomatic care, such as for fever, we can give a plain paracetamol. So if patient is having some cough suppressant, rhinitis, some antihistamine, and we can also prescribe some antibiotics in high risk patients. And case to case basis, we can think of giving oseltamivir also, because we don't know whether even there is some other viral illness such as swine flu. So this oseltamivir, it is an antiviral, and it has some function even in not great, but some function even in COVID. And who are the high risk patients? So elderly, age more than 60, with comorbidities such as coronary artery disease, so CKD, and chronic liver disease, hypertension, diabetic, chronic lung disease. So in these patients, you should be very careful because they can deteriorate very rapidly in this condition. So we usually give some antibiotics also, and we can also add oseltamivir. Now the patient is presenting to you with moderate to severe illness. What should be done? So you should admit him in a designated critical care unit. See, routine critical care unit without proper isolation facilities, the patient should not be kept there, because this patient is a huge source of infection, and other people and healthcare workers can also get infected easily. And you should start empirical antibiotics as per local community acquired pneumonia guidelines. So whenever a patient is having some moderate to severe respiratory disease, probably of infective etiology, we should give some broad coverage. So generally in our country, for community acquired pneumonia, for patient admitted in hospital, we usually add a broad spectrum beta-lactam with macrolides such as azithromycin. Again, oseltamivir, oxygen support if at all he is having any features of hypoxemia. So then you can start an important anti-malarial drug called as hydroxychloroquine. So they have found out that hydroxychloroquine can modify the pH within the host cell, and that can reduce the activity of virus further in the host cell. So it is generally given as 400 mg BD followed by 200 mg BD for next 5 days. And you should also consider antiviral combination used for HIV, lopinavir, ritonavir, protease inhibitors. So this can interfere in metabolism of the virion. So protease inhibitors, lopinavir, ritonavir on case-to-case basis. So there are some separate guidelines where lopinavir or ritonavir should be given in our country, that I will discuss in the next slide. And important in the hospital, I should avoid nebulizations. So because nebulizations can generate lot of aerosols in the room, and people visiting that room can also get infected. So it is better to use a metered dose inhaler. So a metered dose inhaler will be like this, and I connect it to a spacer, and I ask the patient to inhale from this space. So in COVID-19, so routinely nebulizations are avoided. So we give a metered dose inhaler, put in a spacer, and I ask the patient to inhale the drug. And steroids are routinely avoided. So they might be helpful in refractory shock and cytokine release syndrome. So the important cause of mortality in COVID-19 was found to be cytokine release syndrome. So whenever the virion or virus particle enters the lung, so sometimes your lung can give an hyperimmune response, resulting in release of so many cytokines that can further lead to lung damage. So to bring down that inflammatory response, so one can add some steroids, but routinely in management, steroids are not indicated. Then administration of lopinavir ritonavir combination in our country. So most important thing is he should be a lab confirmed patient and symptomatic with any one of the following. So complications such as hypoxia, hypotension, new onset organ dysfunction, one or more. So increase in creatinine by 50% from baseline and reducing GFR and reducing urinary output. So GFR decline more than 25%, urinary output less than 0.5 ml per kg for 6 hours. All this indicates some renal dysfunction and decrease in the GCS score. So the sensorium or Glasgow Coma Scale score by 2 or more, any other organ dysfunction. And also in high risk groups. So lab confirmed symptomatic patients, if they're belonging to high risk groups, age more than 60 years, diabetes mellitus, renal failure, chronic lung disease, and immunocompromised basis and immunocompromised persons. And again, this is not something routinely given, so it has to be decided case to case basis, and these are the current indications of this lopinavir ritonavir. And generally, so 2 tablets are given twice daily for 14 days. So that is the usual recommendation. So lopinavir ritonavir 200 mg 50 mg dose. Then now you have done all this, but this patient is with hypoxia, is worsening or not improving. So what to do next? So if a high flow nasal oxygen is available, you can connect, or you can also connect him to NIV. But use these things very carefully, because these things are having highest aerosol generation, and because of these aerosols generated in the ICU, so we healthcare workers can be affected. So this is a high flow nasal cannula, you can see. So it is going to supply very good amount of oxygen. It can improve the hypoxia of the patient. And next is NIV. So non-invasive ventilation. So it is a positive pressure ventilation given through a face mask, and generally because of risk of aerosol generation, we prefer a mask like this. So this is a full face helmet mask. So there will be a mask which is just like a helmet, and there will be connection, and because of that the aerosol generation can be reduced. So if invasive mechanical ventilation is indicated, now the patient is not improving with this, or there is some absent breathing, severe respiratory distress, central cyanosis, shock, coma, or convulsions. So in these cases, you should put an endotracheal tube and connect to a ventilator. This is invasive mechanical ventilation. So we should intubate with the necessary precautions. So you can see here all these people are wearing the personal protection equipment, completely covered, and they are intubating it. If at all a video laryngoscope is available, it is better, because it will decrease the time. You can easily access into the trachea. So this is the management of a patient with COVID whenever his hypoxia is not improving or it is worsening. So you can try nasal oxygen, but NIV, be careful, they can generate aerosols. And you can go for invasive mechanical ventilation, and you should make sure you are intubating with the necessary precautions, or else you will get infected. Then whenever you connect the patient to a ventilator, the management is similar to ARDS, acute respiratory distress syndrome. So to avoid the lung injury, you should make sure the volumes delivered are a bit less. So we generally go for low tidal volume mechanical ventilation, 4 to 6 ml per kg body weight. And to decrease the alveolar injury, and you should make sure the pressures are also not elevated. So P plateau pressure less than or equal to 30 centimeter H2 bone. So these two are done to decrease the ventilator associated lung injury. So by controlling the pressure and giving less volume, we can decrease the ventilator associated lung injury. And like any other invasive mechanical ventilation, good sedation and neuromuscular blockade to relax the patient and facilitate ventilation. So whenever you relax the patient, the ventilator can do its job very, very easily without any patient ventilator dysynchrony. So patient not fighting with the ventilator. And one should give adequate PEEP to improve oxygenation. So in refractory hypoxemia, so we have methods called as prone ventilation. You can see normally a patient is put in supine position and ventilated. So you can also put a patient in prone position and ventilate. So the advantage of prone ventilation is whenever I put a patient in prone position, so the diaphragmatic compression over basal alveoli will be relieved, and the alveoli in the lung bases will now start expanding, taking part in gaseous exchange, and it can improve oxygenation. And we also have ECMO. So ECMO is extracorporeal membrane oxygenation. So in this method, deoxygenated blood from patient's body is pumped into a machine called as membrane oxygenator. And within that machine, the blood is getting oxygenated, and oxygenated blood is sent back into patient's body. Because oxygenation is happening outside the patient's body, it is called extracorporeal. And the name of the mission, membrane oxygenator. So these are some salvage measures. If everything fails, one can go for prone positioning and ECMO in management of ARDS related to this COVID-19. And what are the other therapies, other attractive therapies? So ribavirin, it might be helpful. And other attractive therapy, interferon beta 1. So this is an immunomodulatory drug. It can enhance the innate and adaptive viral immunity. And we also have another attractive drug called as tocilizumab. So it is anti-IL-6. So as I told you, in the COVID-19 patient, as a complication, there will be cytokine storm. So there will be lot of cytokines released, which will further damage the lung. So one such is IL-6. So if you can neutralize this IL-6 by giving an antibody, there was improvement in patients with severe illness. Another attractive drug is remdesivir. So this is also an investigational drug. So recently a trial is going on. Most probably it might be available everywhere. So this is also going to inhibit the virus. So this is also helpful in management of COVID-19. So as of now in our country, we are having hydroxychloroquine and also lopinavir ritonavir combination for use. So other drugs still it has to be approved for routine use. And another attractive method is antibodies from convalescent plasma might also suppress viremia. So if a patient has recently recovered from COVID, so we are going to take his blood and we are going to separate the antibodies, and we can also inject it to a patient, a new patient who is suffering from COVID-19. So this was found to be helpful in few limited studies. So recommendation for empirical use of hydroxychloroquine for prophylaxis. So the next question is, now I am a healthcare worker, how should I protect against this? See, always most important is good hygiene and personal protective equipment. So in our country, even hydroxychloroquine is indicated, but it is only in certain indications. It should not be used routinely, indiscriminately in all population. So who are those eligible individuals? So eligible individuals are asymptomatic healthcare workers involved in care of confirmed cases of COVID-19. So if you are a healthcare worker and you are involved in care of COVID-19 patients, you can take this. And asymptomatic household contacts of laboratory confirmed cases. So even in house there is another person who is having frequent contact with COVID-19, no symptoms. So in these conditions, only you should take chloroquine. So the doses for healthcare workers, 400 mg twice a day on day 1, followed by 400 mg once weekly for next 7 weeks. So whereas for household contacts, 400 mg twice a day on day 1, followed by 400 mg once weekly for next 3 weeks. So it should be used only in healthcare workers who are getting contact to a COVID-19 positive, household contacts of COVID-19 positive patients. And very important is when it should not be given. Recently I have seen a report where a 4-year child was given hydroxychloroquine and presented with complications in a hospital. So it is not for routine use, so please don't give it routinely for everybody, and it is not recommended in age less than 15 years, known retinopathy, known hypersensitivity to the drug, G6PD deficiency, and patients having chronic cardiac disease. So this hydroxychloroquine can cause cardiac toxicity, QT prolongation. So already patient is having some cardiac disease and tendency to develop arrhythmias. This should not be generally given, or it should be given only under medical supervision. And discharge policy. So generally when you are dealing with a positive case, so you go with the management protocol as we have discussed earlier, and discharge after chest x-ray has cleared and 2 specimens turn negative within 24 hours. So for discharge, so there should be clinical recovery, chest x-ray recovery, and most importantly 2 consecutive specimens should be negative within the 24 hours. So if there is a suspect case and the result is negative, so this patient is required to stay in home for next 14 days. If at all he develops any symptoms, he should immediately report to the medical authorities. And this is a brief gist about and summary about the management of COVID-19. So the guidelines as of now. So get ready to fight, because what we are going to fight is very, very huge. So this is something which has crashed a lot of countries, brought many countries onto their knees, and economy and people's lifestyle have completely changed. And this is a once in a lifetime opportunity for all of our healthcare workers, so to protect and fight for our country against this COVID-19. So let us stay united and fight against this disease. So thank you and all the very best.